Okay, we're going to get started. Thank you so much for coming to Medical Grand Rounds for June of 2023. This is the last round before summer break, and we're very excited to have one of our RVH's endocrinologists here to speak with today. Before we get started, though, I want to thank, first of all, Mitch Green and Amy Dempster. Mitch is, of course, our academic specialist in the hospital. He coordinates all these rounds and makes them happen, and Amy is an OTN coordinator and will provide us the ability to stream these both live. People are logged on right now listening, and also to be archived and be watched at a later date. This is going to be one of those ones your colleagues who couldn't be here are going to want to watch later for sure. So today we're really happy to welcome Jake Zamora to Grand Rounds. Jake went to medical school in Toronto and then went on to internal medicine and endocrinology in Vancouver. Luckily for us, came back to Ontario and in Toronto. Completed further training in endocrine, reproductive endocrinology and male infertility in Toronto. And then we luckily recruited him up to RVH in Barrie, where he and his wife and daughter enjoy camping apparently outside, which is the perfect location for it. So he's here today to talk to us about something that no one's ever heard of, like Ozempic. And the other ingredient-based therapies in diabetes. So let's put our hands together and welcome Dr. Peter.
Alrighty. Can everyone hear me okay? Perfect. Yeah, so thanks for having me. As Chris said, really hoping to talk a bit about a very hot topic these days, especially with Ozempic being so popular. And we'll get into that and touch on some of the off-label use of Ozempic as well, and dive into some more details around that. But yeah, I certainly encourage any questions and things that come up, because I'd rather speak about them as we hit and touch on those slides. But yeah, just let me know. So look there. There we go. Off to a good start already. That's good. Yeah, so a bit about outline. So I'll go into a bit about the history of our incretin-based therapy. We'll touch base on some of the physiology very briefly. Then go into DPP-4 inhibitors, GLP-1s, then sort of the next step, which is more of the dual combination therapy, which should be available later this year. So first of all, conflicts of interest, none. So a little bit about the history. So actually, developing the incretin therapies started almost a century ago, where they first found that some of the duodenal extracts actually has been found to stimulate the pancreatic cells. So they found a response from infusion of these extracts and found that the pancreas will indeed respond to this. It wasn't until sort of 30 years later, lots of delays with wars and whatnot in the way, but that ultimately the term incretin was developed. And the idea being, again, that hormone from the gut that ultimately stimulates an internal or endocrine hormone, essentially. Another 30 years and another war later, they eventually coined the term, like the incretin effect they started to describe. Now that is a direct response where they found, interestingly, that a glucose load that was absorbed orally had a much greater response than that admitted IV. So the idea was that there was some type of molecule, some type of effect that was stimulated by the gut that led to a greater response at the level of the pancreas. Further purification and research later, they ultimately started to identify and isolate various hormones. So GIP came around in the 70s, again, showing that there was some improvement in glucose tolerance, and then also demonstrating that insulinotropic effect with this hormone. Further identification eventually found GLP-1. That was into the late 80s. Interestingly, in the early 90s, to start to build towards medications, they actually extracted Exandin 3, which had approximately 50% plus or minus homology to some of the GLP-1 molecules, but it was actually extracted from the Gila monster. So a lizard that's in, I think, southwest US, they interestingly helped to identify and isolate this molecule and help to develop medications that we now use clinically, which is just more interesting. Then next steps really into the early 2000s, we then found DPP-4 inhibitors and GLP-1 use starting to evolve into diabetes, but still not the full effects that we're certainly seeing today. So a little bit about why these are becoming more and more useful in our world of diabetes. So a bit about the mechanism. So again, we take something in, we eat, that goes is digested, and then ultimately stimulating gut hormone production. So GLP-1 and GIP are the main hormones that we've identified. Truthfully, there's certainly more out there, but these are the main ones that we're targeting and isolating at this point in time. Now, those hormones are broken down by DPP-4, which hence the DPP-4 inhibitors block that step and then cause an activation of those hormones, whereas those hormones, without being broken down, will go on to have their sort of systemic effects. So stimulation of the pancreas, the beta cells to produce insulin, and then also the alpha cells to essentially suppress glucagon production, then therefore prevent hepatic glucose release, and then increasing overall glucose intake within the cell. Now, there's other systemic effects that we did find as well with these GLP-1s. So this is where it's really becoming more popular, and it's predominantly around the weight loss side of things as well, which obviously helps diabetes, but maybe why it's, certainly hit the ground running recently. So appetite suppression is a big one, decreased food intake, subsequently leading to weight loss. And then also you're seeing that, again, that delayed gastric emptying, which is sort of this feedback cycle to further promote appetite suppression and weight loss. So all in all these effects together leading to improvements in A1C, improvements in glucose tolerance, and all these types of things. Now, diving into the DPP-4s, now we do use them a lot. It's certainly in hospital, they're on most hospital formularies, but I find when we're starting them, we don't always appreciate the true impacts that they're having. Now, Januvia is certainly a very common medication that we're using. It's combination with metformin and Janumet, so we're seeing a lot of its use. Now, in those studies, just to give a good sense of what the actual impact of those medications are, most of the studies you're going to see anywhere from a sort of a 0.3 to 0.5 A1C reduction, so not huge A1C reduction. Now, as these medications have evolved, we've also brought up into a lot of light of the importance on the cardiac protection and cardiovascular system. So Januvia in this realm ultimately did not find any improvement in overall composite outcomes as far as cardiovascular concerns are brought up. Now, as far as hospitalizations for things like heart failure, and this will come up as we get into some of the other DPP-4s, but there was no increased hospitalizations for heart failure either. Now, some of the concerns, because anything that ultimately stimulates the pancreas to make a bit more insulin, we always do worry about that overstimulation or irritation of the pancreas. So pancreatitis was a concern and has been a concern with these medications throughout the whole course. Now, numerically, there was more pancreatitis in this, though not statistically significant. Truthfully, the more common side effects that will come up, throughout this presentation is more so the GI side effects. So a lot more nausea, diarrhea, bloating, and these types of things. Sorry, it's quite fine print, but at the bottom, ultimately saying there's no real differences in malignancy, other respiratory or other types of concerns as far as reactions. They're overall quite well tolerated, but things to look out for is certainly the pancreatitis and GI stuff. Now, moving along to some of the other DPP-4. So linagliptin, I find I'm using a bit more commonly over Januvia. Sometimes it's just practice patterns of what you're taught, going through education, but Prudenta, and I'll get into this in a slide, but it's more so how it's metabolized. You don't have to worry about that dose reduction depending on the renal function, which provides that flexibility, because that's one of the things we're obviously always worried about with our diabetes population is the worry that it's going to have on kidney function and the adjustments we have to make as throughout their course with diabetes, because, we're not always the ones that are, sending them on their way. We're often following them for years, if not decades of their lives. So seeing them throughout a whole sorts of different admissions to hospital and complications. Now, linagliptin did ultimately have a bit more A1C reduction, depending on where it was used in the sort of the arsenal, if you will. You saw anywhere from a 0.5 to a 0.7 dose reduction. So linagliptin on its own had about a 0.4 production, whereas when you start to add it to things like metformin, it has actually potentiates it a little bit more, so you get closer to the 0.6. And then when you're adding it with things like sulfonylureas or other medications, then you're seeing further closer to the 0.7 A1C reduction. So there is some potentiation there, but again, not overly impressive. Certainly those individuals who are finding, certainly in the hospital, where they're coming in with an A1C of 12 or 13, right? Now, again, similar to the Januvia, we're not seeing really any significant changes as far as cardiovascular outcomes. There was, interesting, sort of a bit of a signal that there was less progression of nephropathy. So, that's something to keep in mind, but truthfully, they didn't actually show statistically significant changes at secondary composite outcomes as far as kidney and things. Now, in this particular study, when they're looking at the cardiovascular outcomes, they ultimately did see a 0.5% reduction in the A1C, and then again, no heart failure reduction. course, there are no heart failure, increased heart failure admissions. Now, again, as far as tolerability with the medications, again, it's one of those nice ones that you don't actually have to dose reduce with regards to the kidney function, predominantly excreted in the stool through the biliary system, and only a slight bit is 5% or so through the urine. So again, it's one of the options that I tend to lean to a bit more in hospital, at least, as opposed to Januvia. Some of the concerns that did come up, again, the acute pancreatitis statistically not more, but numerically a bit more. And the pancreatic cancer, again, numerically more, but not statistically significant. Now, this is the one that probably came out of favor pretty quickly, because in the initial study, when they looked for cardiac safety, there was an increased admission rate for heart failure in particular. Now, there was follow-up studies with the meta-analysis in 2018, though by then it's ultimately too late, because by then we're starting to introduce our GLP-1s, Januvia and Trudhesa have already sort of hit the ground, and most people aren't starting this at this point. You still see the odd patient on it, and again, I'm not necessarily rushing to take them off of it unless I'm switching them to something that actually has vascular protective properties. But again, it's just keeping in the back of my mind that there is that potential for heart failure. And then, yeah, just other side effects that they came up in more so the meta-analysis was more hypoglycemia. But the hypoglycemia in most of these studies seem to be more associated with patients that are already on things like insulin or sulfonylurea. So I don't want to spend too much time on the DPP-4s because I don't think, especially as diabetes is evolving, they're playing less and less of a role. We have newer agents, and and I'll touch base at the end about the stuff coming out in the fall. But yeah, we're not seeing huge A1C reductions, no real significant vascular outcomes, and then maybe some delayed progression of albuminuria, but certainly other options out there. The challenge with interpreting this is towards the end of these studies, and certainly as we get the GLP-1s, all of a sudden patients are now on SGLT2 inhibitors. They're on other agents that have added vascular benefits, so they may not fully, reflect or add to the arsenal that we have. Now, I do want to dive into the GLP-1s, and this we'll spend a bit more time in. Like I said, it is very popular right now, and certainly for good reason. So this all started back with Victoza or liraglutide when it came out. So this was the first of the GLP-1s to really demonstrate the true vascular benefit. Now, as far as lower death from cardiovascular causes, we ultimately saw a reduction from 4.7 in the Victoza group from the 6% in the placebo group. Now that separation, it's hard to see on some of these graphs, but that separation does happen, at least on the graphs. You can start to see it at a few months. So you're starting to see some good benefit pretty early on, certainly, showing some necessity to start them earlier on in a patient's course and kind of seeing that growth as time goes on. Now, there was lower frequencies of non-fatal myocardial infarction and then non-fatal stroke. And then interestingly, they also saw the lower death from any cause, predominantly driven by the vascular components. Interestingly, that A1C reduction, as I mentioned before, we're thinking, DPP-4s don't actually have that strong of an A1C reduction. It's interestingly, with the Victoza group, by the end of the study, the average difference was only about 0.4% lower than what it was, which sort of speaks to the added benefits from these agents. Now, there's ongoing research, but the thought is that it also plays into the other molecules and the other components that these GLP-1 agonists actually target. So things like some subtle lipid lowering, some blood pressure lowering. There's thoughts that it actually improves the endothelial lining. It improves platelet aggregation. Some different factors that all sort of accumulate to the overall vascular risk. So there are some added benefits just outside of A1C reduction alone, which, yeah, obviously that's what they're trying to take advantage of at this point. Now, the risk, because we're seeing that bigger A1C reduction, we're seeing more, potent molecules. And again, to go back to that initial slide, it's not that DPP-4s and GLP-1 agonists can't be used together. Just to make a note of this, is that basically GLP-1, once you have it in the system, it makes the DPP-4 inhibitors obsolete. It just makes them non-functional because essentially you're instead of blocking the step to make more GLP-1, you're just giving it directly. So you're kind of eliminating that step entirely. So for the most part, when you're starting these agents, you can stop your DPP-4 inhibitors. So as far as the benefits here, so again, just to highlight, so some of the cardiovascular outcomes, and then progression of nephropathy came up as the main contributor to the improvement on the microvascular side of things. So again, this just highlights that A1C change over time, the initial 1.5% drop in the first sort of 3 months, and then the weight reduction, which we'll dive into a little bit more, but they essentially saw about a 4 to 5 kilogram weight reduction in that. As far as safety is concerned, again, the pancreatitis came up, not significantly different between the two. There was a bit more cholecystitis, which did come up and came up again in another trial, which we'll touch base on. But ultimately, they also saw increased injection reactions along with the GI side effects, which is the predominant driver of the complications and the leading cause of why patients would actually stop these medications in general. Now, as I said before, the weight, I don't want to spend too much time on the weight, but certainly we'll welcome questions if they come up. So we'll touch base on Victoza and Ozempic. Now, Victoza, liraglutide, Saxenda, all essentially the same thing, just different dosages and marketing and things. So liraglutide up to the 3 milligrams, essentially Saxenda used in the weight loss population. Now at the higher doses, you are seeing more and more weight loss reduction, and this is in addition to activity and lifestyle changes. So you do see quite a bit more weight reduction in those populations. So in the scale trial, ultimately seeing an 8.4 kilogram loss by the end of the trial, which was after a few years. So yeah, so we're starting to see some improved weight loss there at the higher doses, as I said. Now, diving into Ozempic. Now, this is where we really start to take off and why this drug became so popular is that we are certainly seeing far more benefit at the cardiovascular level. So, you know, the composite cardiovascular outcome, we're seeing a 6.6% difference compared to the 8.9 in the placebo. Again, seeing lower risks of non-fatal myocardial infarction, as well as other vascular endpoints. A1C reduction seems to be greater and maintained for longer, which is interesting. So they're starting at 8.7%, both at the 0.5 and then both at the 1 milligram dosing. Then, you know, we're seeing that A1C reduction maintained for longer throughout the course of the trial. The weight loss reduction, and we'll touch base on the weight loss trial, but 3.6 kilograms and 4.9 kilograms. So quite significant in a time frame where they're not actually also focusing on the weight loss. They're not actually providing lifestyle or activity and dietary advice as well. So, you know, we're already starting to see that flare. And again, that separation of the curve where we're starting to see those benefits is happening pretty quickly. It's happening within a few months after drug initiations. And then this is just, again, highlighting the change in the blood sugar and the change in the weight and how you get that rapid drop but then maintained. Now, one of the concerns that comes up with most patients that, you know, everyone's worried about an injection. Also why Ozempic did become somewhat more popular, being a once weekly medication versus a once daily with Victoza. That sort of prompted them to develop Rybelsus, which has been available for some time now, though I haven't seen the same uptake. I certainly have a few patients on it, but the timing is I'm not sure how many people actually have used this, but it's you basically have to time it between 36 minutes before your first meal a day. It has to be an empty stomach. You know, I know our educators are advising to, you know, have it at the bedside to you know, take it first thing in the morning before you even get up and go down to go down for breakfast. And because people it's easy to forget, and then it essentially just doesn't work. So there's some sort of technical difficulties that we find with it, but the other thing is the interpretation of the cardiovascular benefit. So the study was geared towards non-inferiority, though it wasn't significant for superiority. Interestingly, they did so as far as numerically, you know, reductions in all-cause mortality, death from CV cause. There was a slight increase, actually non-fatal MI, but again, it wasn't geared or adjusted for that. And then again, some reductions in non-fatal stroke and heart failure. So there was some signal there. And certainly I suspect that if they were to have the amount of people that was geared for a superiority trial, that we would see those benefits. But it's also just plays into why it never really took off compared to Ozempic. It's also more expensive just for the oral versus injectable. Rybelsus, I mean, you are seeing good A1C reduction, similar 1.2% initially, and then it kind of levels off anywhere between 1% or so, and then you're also seeing the weight loss benefit. So I think we're just waiting on the trial where they're going to actually bump up that dose to focus on the weight loss side of things. GI side effects are the predominant risk with Rybelsus, similar to Ozempic and Victoza, truthfully. Again, not huge numbers, so it's hard to tweeze out, but GI is where people are going to come to you. Now, again, Ozempic is off-label for weight loss. It's approved. Semaglutide is approved for weight loss under Wegovy. We just don't have it available. Speaking to the drug company, essentially it's more so about the device, the actual pen itself, they don't have enough of, to the point that they're actually taking a lot of our insulin pens and putting them into cartridges to make more Ozempic. So it's obviously a very popular drug because of the weight loss reduction. So, when they add it to behavioral modification, so activity, diet, and all these things, we are seeing anywhere from 10 to 15% weight reduction within a few years, and it seems to be maintained, which is quite good. Now, again, the other impacts, and this is highlighted, I thought this graph from the Wegovy trial did highlight it a little bit, is that where we're going to start seeing those vascular benefits is around the associated sort of risk factor modification. So weight reduction for sure, weight circumference for sure, but we're also starting to see now lower blood pressure, lower lipids, lower CRP, lower A1C, lower fasting insulin levels. So all these things that can accumulate to that added vascular protection. So each individually, maybe not a huge deal, but when they all add up together, that's, I think, what's the main driver for why we're seeing these improvements. Now, the question is always, okay, which one do you start, especially if it's for weight loss, if it's for vascular protection. Truthfully, when they do the head-to-head to Victoza to Ozempic, pretty much Ozempic coming out on top for the most part, both for tolerability. Interestingly, one thing I just wanted to highlight, it's really hard to see on this, but although the reported side effects are wildly high, 85% side effect rate, the amount of tolerability and people willing to actually stop it drops down to like 2 or 3%. So most people in Ozempic are continuing on, and then 12% in the liraglutide. So it's, even though they're experiencing these side effects, it's not enough to make them stop based on the discussions, based on the benefits, based on truthfully the weight loss. I don't want to forget about these two because they are certainly out there. Trulicity, so dulaglutide, again, you are seeing that vascular benefit. Where I find this agent in my arsenal for treating diabetes is that it's the convenience of the once weekly. The pens, they're different pen. They're sort of preloaded. They are helpful. You don't see the same weight loss benefit. So somebody who you were looking for that vascular benefit, maybe they're concerned about their weight loss, I might be grabbing Trulicity over Ozempic. As far as tolerability between my patients, it's very variable. So it's hard to know, but I certainly have a couple that have been on Trulicity, though didn't tolerate Ozempic and not seeing that same weight loss that they were worried about. A1C reduction by the end, 0.6%, but again, that initial drop is up to 1%, and then you are seeing that weight loss, but only about 1.46 kilograms. And then exenatide, we can sort of skip over this, but again, you're seeing the weight loss reduction, blood pressure, and seeing reduction in the primary outcome. The only issue is with superiority, not statistically significant. There's a few secondary endpoints that people often will ask about, and that's what we're sort of extrapolating. And one is mostly on the kidney, right? So it's reported in all the outcomes, but only ever reported as a secondary outcome. Now, across the board, they are showing in benefits, especially when they're doing the composite outcomes with microvascular complications, retinopathy, and nephropathy. It's predominantly driven by the nephropathy protection. So liraglutide did show decreases in the compensate outcome. Semaglutide showed 36% reduction in the combined renal endpoint, and then dulaglutide showed ultimately less eGFR decline over time. And then all of them actually did prevent the development or progression to macroalbuminuria. Now, again, speaking to some of the other means of what it's doing, it's not just the blood sugar, but the thought at the level of kidneys, again, the blood pressure, the impact it has on the cholesterol. There's thought that it has impact on oxidative stress at the level of the kidney, glomerular hypertension, and all these different, components that are contributing to this vascular and renal protection. This is more so for interest, the summary of all the renal outcomes for that. So yeah, and interestingly for Ozempic, and this is some newer data, and I'll touch base on the new agent as well. But Ozempic as far as fatty liver disease, so certainly a useful tool in our arsenal. So interesting, you're seeing about a 59% reduction in NASH with Ozempic. Interestingly, the dosing in this trial was a little different. So it was a daily dose of Ozempic up to, I think it was 0.4 milligrams daily. So it's closer to what, by the time the week rolls around, it's closer to the actual weight loss, like the Wegovy trial. But they did dose it daily, so there is that component of it. But they did slow the progression of fibrosis within that population, but not necessarily reverse it. So there was certainly benefits at the level of the at the liver, but we're not essentially taking a back step on the fibrosis side of things. There was also a very dose-dependent reduction in their liver enzymes as well. So both ALT and AST decreased throughout the trial and stayed there throughout the couple of years of follow-up. One thing that came up a couple months ago, and this was part of the discussion that we had initially on with patients with these agents. So thyroid cancer, this study came out a couple months ago. The initial thought was it was mostly drawn out of rat models where we thought there was higher rates of medullary thyroid cancer with these GLP-1 agonists. Now, it didn't really seem to play out with our patients, at sort of the human level, if you will, but recently, they did sort of a meta-analysis and a retrospective study looking at was there higher rates of cancer seen in patients who have ever been on these agents. And it did indeed show that there was an increased risk. Now, there's been some criticisms to the study. I don't think it hasn't changed my practice patterns personally, but certainly it is a discussion that I include. Historically, if you saw my old notes, they'd say, oh, medullary thyroid cancer is theoretical risk, but now I'm sort of including all the thyroid cancers. Now, the challenges with using diagnostic codes, misclassification, there's challenges with coding medullary thyroid cancer versus any thyroid cancer. So calcitonin, they depended on the calcitonin levels, CEA levels, and actual treatment prescriptions to determine whether or not it was papillary or other subtype of thyroid cancer versus medullary thyroid cancer. And then the challenge too is that the codes don't actually distinguish between readmissions versus a single admission and with the same individual. So there's a few concerns there. And then, like with all our medications, the question is whether or not patients actually fill the prescriptions that we give them, which this seems to be better than most as far as GLP-1s, but still not perfect. Retinopathy is something that comes up frequently as well. Now, this was always a concern, truthfully, with any diabetes medication. And the thought is that it's not necessarily the mechanism or the actual GLP-1 agent itself. The thought is the speed at which it's reducing that A1C. So going back to those slides where you saw that initial fast A1C reduction, that's the worry that we have at the level at the eye. Now, some people would recommend getting eyes checked before starting these agents. I think it's going to be very dependent on where that patient's at in their overall course of, other comorbidities, where their A1C is at as a starting level. It doesn't seem to be, for at least from this meta-analysis, that it's specifically the GLP-1, but again, it's more the actual speed of the A1C. Another population that we see this a lot in is actually our pregnancy population. We worry about the rapid change in their sugars around that time. And that's why we do a screen quite frequently for retinopathy early on in the pregnancy and throughout. It's the same sort of concept, but it's certainly something to consider. People who have already do have retinopathy, I'm often reaching out to our ophthalmology colleagues and kind of getting a blessing, if you will, just to make sure that it will be monitored. They'll be able to watch it. It seems to be that when they're already being followed, whether they're getting treatments or not, and they're actually attending those appointments, it doesn't seem to be putting them at greater risk. And I know most of our ophthalmologists are more than happy just to get their overall blood sugars under control, just because they know sort of the greater value that's at hand. Now, where do these reflect in the guidelines? Certainly it's evolving, and in Canadians, we're always going to be a bit behind, but where it's really coming up is now sort of changed how we approach our add-on therapy. So metformin pretty much is still our go-to starting, though whether they have pre-existing vascular or whether or not you're just someone at risk, they're basically saying you should be starting GLP-1, they should be starting SGLT2 inhibitor. Where that changes a little bit, maybe you're going to start a bit more SGLT2 in your heart failure population, but certainly, with most of our diabetes population, they're going to end up on multiple agents, and that's really what we're looking at adding. So it's certainly where we're at, and we're just going to be seeing more and more of it as it becomes a standard of care, and as that standard of care reflects coverage and things. This is just a summary of all the vascular benefits. So now Ozempic's sort of taken over as far as the go-to agent in diabetes and certainly weight loss at this point. Like I said, it's off-label for weight loss, but it's used a lot. Now the question is what's next, and this often comes up. So it's already available in the States. So this is sort of where the next agent is going to be. So it is a dual GLP-1 and GIP agonist. So the idea is that it's going to stimulate the first phase and second phase insulin response. It's going to reduce glucagon levels, delay gastric emptying as it did before, decrease food intake. Interestingly, it also enhances sort of the postprandial lipid buffering. So you're kind of getting some increased sensitivity to insulin. So again, potentiating that. But you're also potentiating the GLP-1 through that GIP. So you're getting more sort of stimulatory effect, if you will. And how this is essentially played out, and they sort of just went for it and compared to Ozempic. That being said, they went to the higher dose of the tirzepatide, the 1 milligram of the Ozempic, but you're starting to see some pretty big and impressive A1C reduction. So 2%, 2.2%, 2.3% at the various doses of the tirzepatide. Weight reduction, and this is again not the weight loss trial, which I'll touch base on afterwards. You're already starting to see 7.6, 9.3, 11.2 kilogram weight loss. So nearly double what you're seeing at the diabetes dose of Ozempic. Now, adverse events, certainly more GI side effects in the tirzepatide group. Again, it seems to be that not enough to get people to stop. You're still in the sort of the 4 to 5% range of people who are actually stopping the medication. There wasn't any difference in thyroid cancer, at least in this shorter follow-up. No death was thought to be considered secondary to the medication, and then the cholelithiasis came up, but again, not statistically different. Now, again, just to go on the weight loss side of things, and I think this is where we'll also see some, again, it's just the funding of it is always tricky, but when you start adding it to weight loss, to some of the lifestyle modifications or diet, activity, and these types of things, all of a sudden we're starting to see 15%, nearly 20% weight reduction within a couple of years and maintain. So again, this is, I think they're estimating, I spoke to the rep not too long ago, but they're estimating it should be available in September. And then there'll be a delay from that for coverage and all that kind of stuff. But so it will be here soon. Not to harp too much on this, but the challenge is that they don't, where there might be a further delay in starting this agent is that there's not quite the vascular trials out yet. I'll say in a moment here, but it's ultimately supposed to be out compared to Trulicity in, I think, 2024. So we'll start to see those trials come out. But you're already starting to see hints, lower lipids, lower blood pressure, as we did with the GLP-1. So we're starting to see those hints that we're going to see some vascular benefit as well. So they did do a meta-analysis on those weight loss trials, and certainly the first one actually was against insulin, so against Tresiba, and then Ozempic and the weight loss trial. So they sort of pooled that analysis. They didn't show any increased risk of cardiovascular events. Obviously, it wasn't pooled towards or geared towards superiority, but you're starting to see that separation. So all indications sort of indicate that we're going to be heading towards another vascular protective medication here. And then again, this came up in the fall at the European presentation, but again, more effects at the fatty liver disease, as far as fatty liver disease is concerned. So using MRI technology and certainly looking at the actual fat distribution, we're seeing less fatty liver disease, and then understandably less, visceral and peripheral adiposity as well. So yeah, so we're starting to see some big benefits outside of just vascular as well. So I kind of sped through that, and I certainly encourage any questions, but just to kind of summarize here. So DPP-4 inhibitors, still certainly there is a use for them. They don't have that same cardiovascular endpoints that we've seen with the GLP-1s or with the, obviously the new dual agents, 0.4, 0.7% A1C reduction. GLP-1, certainly our go-to at this point in time. We're starting to see that, vascular protection, the liver protection, certainly counsel on your thyroid disease and screening for the retinopathy and these things. And then dual GLP-1 and GIP it's coming. So we'll certainly start seeing more and more of that. And so I guess we'll have to stay tuned for that update. But anyways, that's it. But yeah, like I said, I certainly encourage any questions or concerns or anything.
Okay, we're gonna do questions. If anyone has questions, we're gonna pass the mic on so people online and the target able to hear. Any questions for Dr. Zamora? Okay, I've got a couple. What's the role with someone who's already on insulin? Is there one?
That's a great question. There will always be a role for insulin because especially early on in the case, and you know, that's what we're seeing in the hospital. We're seeing the patient who has not been followed up with healthcare. They're presented with often decompensated hyperglycemia. I'm often just grabbing insulin before any agent to settle the sugars down. You often by giving the pancreas a break, you can sort of tap into that reserve and then initiate therapy. I think we're in an age where I'm trying to, my end goal is always these types of medications, the vascular protection. But I don't want to burn that bridge before we get there. Like the same thing with the SGLT2 inhibitors. Someone comes in with an A1C of 15 and we throw them on SGLT2, all of a sudden they're peeing out all that sugar, potentiating, you know, DKA, and then we're saying, look, and now they can't be on that medication anymore. And maybe it was just a timing thing. Maybe it was just that we need to slow those sugars down. Now, I'm still grabbing insulin in those scenarios. Now, a lot of people are already on insulin. Looking at their A1C and what their buffer is, ideally they're monitoring and kind of get a sense of what their sugars are doing throughout the day, because certainly a lot of these people were able to reduce the doses of insulin. I had a gentleman actually we saw last week. He came to me, immigrated from Brazil. He was on NPH, so cloudy insulin, so already kind of older insulin. Within 3 months of starting Ozempic and him being on insulin and a couple other agents, he's only on metformin, Ozempic, and SGLT2. So he went from having insulin, multiple daily doses to nothing, and now with vascular protection. So we are certainly seeing that benefit. But yeah, it's certainly something you have to pay attention to. It's the risk for lows. And a lot of those lows that they saw in the studies are people who are on sulfonylureas or insulin.
And like quality of life issues, some to come off insulin.
Oh, yeah.
Life changing for those people. When they're in the hospital, you know, people get in generally in the ICU, generally stop-water role because of drug interactions or variations in renal function. What's the interaction profile like with these drugs? Does it play well in the sandbox with other things?
It seems to. It's all GI, and it depends on the patient. Some people are certainly more sensitive. I'm not seeing a lot of drug interactions. As far as hospital, I think that's always going to be the safest thing. It's, you know, trying to get them through this acute period so that we're not burning bridges with their medications, because it's easy enough for us to restart everything afterwards. It's just get them through whatever brought them to the hospital and then get them back on it. So I certainly agree insulin is probably the safest thing to do in a hospital.
Perfect. And we got a question online. Okay. Where do the SGLT2 inhibitors fit into diabetes management? And would you go for a GLP-1 agonist?
Depends on the patient. So, you know, SGLT2 inhibitors, you know, and especially with the evolving research, we're finding outside of A1C as well, we're getting vascular protection. So I think it's going to be in our arsenal. You know, diabetes or not, there's a good chance that that's going to be one of our add-on medications. I would say if they're symptomatic and they're peeing more, I'd probably grab a GLP-1 over an SGLT2 inhibitor. If they're presented with heart failure, then I'm grabbing an SGLT2 inhibitor over GLP-1.
Okay. Question in the back. Rushi.
Okay, I think I got most of this. The one question that I'm trying to answer to myself is, what about in the elderly? Does that change use of the GLP-1s, especially since we don't really worry as much with vascular advantages, right?
Absolutely. There's definitely a role. In the elderly, the concern comes up with the weight loss, right? So many elderly who are frail, you actually don't want too much weight loss, but some of them are coming to us with insulin, progressive dementia, or cognitive issues. We have to get them off things that can cause them lows. You know, I'd say it's a daily discussion of people coming to us who we worry about their self-management and identifying those lows. So I'd preferentially grab a GLP-1 agonist so that they don't have to monitor over insulin in that population. Now, it might be the individual that I'm up titrating slowly to make sure that they are tolerating it. We're making sure that we're touching down a bit more frequently, but it's the lows are what's going to do somebody in that individual.
What about the side effect profile on the elderly? Do you find the side effect profile higher in the elderly?
Not particularly. I personally, I haven't found that. Most seem to tolerate it quite well, you know, surprisingly. So some, you know, will have it a couple injections, say they'll never touch it again. But, you know, we have a 90-year-old on it. Like it seems to be doing okay. It depends on the individual. If they come to you with a sensitive stomach, then like I said, that's the one I might try to mitigate those risks by slower up titration. I don't know how many of you have actually seen the pens, but you can actually go up by clicks. So even though you can dial it up to 0.25, you can say to that patient, say, you know what, why don't you just go up a few clicks every week, a slower titration to build up that tolerance? Because most of the nausea and things you're feeling at the first dose, the increased doses. Once they hit the same dose week to week, it seems to settle everything down. So there's some little tricks that people have found to sort of help mitigate that. But yeah, I'd say I'm using them, and actually nice to have it as a tool to get rid of insulin in those people.
Hi, my question, I guess, is on the other end of that. Can we use this in our pediatric adolescent population?
Good question. I don't know. I don't treat kids. But you know, so there is evolving evidence in the adolescent population. You know, childhood obesity is increasing. Type 2 diabetes in adolescent is increasing. There is evidence in safety. The challenge we're going to have is what is 50 years, 60, 70, 80 years of GLP-1 exposure? We don't know. We won't know for that lifetime. So it's hard. There is a role, and I certainly, I know my pediatric colleagues and endocrinologists have used it, but there's a lot of unknowns there.
Hi, I guess I'm wondering if the GLP-1s are affordable, which ones are covered, and what's going to happen with the GLP-1 mix.
Yeah, so they are, so coverage on ODB and showing all these things, a lot of private coverage will do it. Sometimes there's some additional forms. The challenge is the people who are in between that, right? So not quite 65, you know, life's expensive. They're already struggling to pay for, you know, food and housing and all that stuff. Those are the people that we're struggling to get coverage for. So it's still is a barrier, absolutely. When the dual comes out, until I think the vascular outcomes comes out, and there's always going to be a delay, it's not going to be covered for weight loss. It'll be for diabetes.
How much would it cost? I was going to pay you out of pocket for a year. Is that big?
That's a good question. Do you guys know?
$1 a month.
In a month. But you can get it at airports now. I saw it in the news.
Hey Jay, thanks for the talk. 2 questions. Are they being used in type 1s?
Weight loss. So yeah, they are. They are. So you're not going to see that same, you know, secretory effect at the level of the pancreas. You're going to see the weight loss components of it. We're certainly using it in type 1s. You still have to be careful because that weight loss will improve their insulin sensitivity. So you do have to counsel on the risk that their insulin needs are going to change. So there's the risk for lows and the same risk for anyone else. But yeah, we are using it in type 1s.
The second question, probably going to depend, but are you switching people from sitagliptin to your agents now?
Sure. Yeah, absolutely. For vascular protection and to have that discussion, the question is always going to remain that, you know, the person who's at target, are we switching them? Certainly with the evolving evidence, I would say even those that are at an A1C of 6.5, we're having that discussion of using agents that are adding that added vascular protections. I have that conversation pretty frequently saying, you know, it's not just the day and age of are you hitting the numbers, it's, you know, how are we getting there? And that conversation comes up daily, really.
Okay, 2 more questions online. Good discussion. So if patients take Ozempic for weight loss, do they have to stay on them indefinitely?
There seems to be a rebound. So if you come off the Ozempic for the weight loss, you can imagine like any hormone, truthfully our glands are quite lazy. If we get a hormone from elsewhere, it's going to turn off our own production of it. So you're going to get that reduction. Now, there's not a lot of guidance on coming off of medication. Not that a pharmacy company would ever recommend or fund a study to come off the medication, but different ways, try tapering off, trying to, you know, emphasize the building the habits that led to the weight loss in the first place. But there seems to be a rebound in weight and appetite afterwards.
And
I've had drummers tell me that GLP-1 agonists prevent renal complications in diabetes. How robust is that data?
Say that again?
Prevention of renal complications of diabetes and GLP-1s. How robust is the data?
I mean, it's secondary outcomes, right, for the renal benefits. So, you know, it's certainly seen across the studies. They've geared it towards the cardiovascular side of things, but certainly I include it in my arsenal for renal protection. Probably not as much for SGLT2 and obviously your ACE and ARBs, but it is in the conversation for sure.
And I appreciate and understanding irony of serving pizza during a talk and reducing food gone and loss. However, pizza's delicious. Okay, no other questions? Okay, any other questions here? Oh, Joe?
Every time I see Rebelsis or Zeppelin commercial, I want to punch myself in the face repeatedly. Is that a recognized sign?
So, no, everyone asks me, the truth is, I don't have a TV. I've never seen the commercials. I don't know. But I'd say daily someone asks how bad the commercials are for truthfully any of these. I've yet to have someone dance in the clinic though, based on the prescription I gave them.
Any other questions? Okay, I'd like to thank Dr. Zamora for a very great talk. Thanks for coming to join us. If people can scan the QR code at your table, give feedback while we improve grand rounds. And thanks for your attention and time, and have a great day. Thank you.